I'm Dr. Thurmond, as you're probably aware of that. And what I'm going to do today is talk about COVID, a topic that I know we are all just totally sick of hearing about. And I'm going to talk about the treatments, the transmission, a little epidemiology, and I'm going to assume that I am a middle school health teacher, which means I'm actually a football coach. And for class today, I'm just going to turn on videos and I'm going to go and play with my phone. So no, I'm not going to do that. But I think, they're listening to someone speak about something and show you words is just, to me, never as useful as being able to see a picture and in many cases some animations, which gets the point across. All the people who did these animations, I'm sure, are far smarter than me in terms of understanding the concepts. But my goal is that, we as caregivers will be able to explain to people kind of how the drugs work, what they do in a way that they can understand, and also explain why the vaccines being used currently are safe and well tolerated, and they're not able to incorporate themselves into your DNA so that you'll grow an arm out of the side of your head or you'll die from leukemia, which, are all reasonable concerns because none of us would want both those things to happen. But at the same time, it's realistically, these are very safe. In fact, that's why when they first came up with these vaccines, it was far easier to create these vaccines than to grow up massive amounts of COVID in a test tube and then inactivate it and then try and inject those bits of the virus. So what I'm going to do is show you a number of videos that are kind of simply instructional, but they're conceptual. And the biggest issue and why I still end up getting called at 2:30 in the morning every night, and I apologize, I'm tired, so my mouth is going to run excessively, but it's because we haven't all gotten vaccinated. And the only way the pandemic will end is if we all get vaccinated, or most of us, or if we all get COVID and we are made naturally immune, or if most of us die and then there are just a couple of people left. But they'll get COVID when they're trying to bury the dead people, so they'll end up with it also. So the point is really just to be able to communicate about the disease and share with people why vaccination is important and why these vaccines are safe and well tolerated. And yeah, there have been some adverse reactions, but I can tell you that for a lot of the adverse reactions to the vaccine, if we had taken, there have been 150 million doses plus administered, which is an astronomical number. And if we gave 150 million people some saline water injection in their deltoid muscle, chances are we'd have just as many people with just as many adverse events, because the likelihood is so low that, other than in some rare individuals with the Johnson & Johnson vaccine, with some head bleeds and things like that, they're generally safe. They're pretty safe. So anyway, I would have gotten vaccinated once a month if I wouldn't have gotten my license taken away for stealing vaccines. So, and strangely enough, I've never had a COVID test, and someone's probably going to force me to. And at some point to get into the movie or something, even though I'm fully vaccinated, we've counted COVID huddles, or I have, and I keep a log of patients that I've reviewed their information, and we're looking at almost 1,300, 1,400, and so it's taught me a lot, and I actually am thankful for the opportunity to be kind of the COVID monitor, because I know so much more about the disease, having gone through so many patients, than I would have otherwise. So anyway, I'm going to start with some epidemiology. And so what we're going to look at is a little video that was actually in the Washington Post. And it's really kind of cool because it helps to illustrate really it says why outbreaks like coronavirus spread exponentially. And we've had to listen to this whole, flatten the curve. And we get tired of hearing about flattening the curve. But what these animations are going to show is really how transmission takes place in terms of what happens over time, and then how the things that we have been told to do, why they actually work, and then how that really decreases morbidity and mortality. And the biggest thing is, preventing semi-symptomatic COVID infections is not, the highest priority, but preventing death and long COVID and lasting symptoms is obviously a really important part of what we're trying to do. So this is, look and go through, then this was done in March of this year. Or no, this is actually a time point of when COVID initially exploded. And you can see that by, between February 15th, where there were, 15 cases total, and March 12th, it was 2,100 cases in the United States. But so this shows on the top what happens. This is just a simple demonstration of one person passing COVID to another. And if we get off of that and go back, actually, well, you'll see healthy, infected is the brown, and healthy is the blue. And then this goes on to show a different thing, which is a recovered person turns purple. So as we look at all these examples, you'll be able to see, and that's what we usually see on the curves that they draw is, infected, not infected, and then recovered. So here's what happens with a change over time if people are just randomly hanging out with one another. One person started with this illness, and you can see on the upper, you can see the curve coming out, and you can see on the left the number of people who are healthy, the number of people who are sick, and the number of people who have recovered. And so it shows it's 200 little dots, and we'll do it again so you can kind of see a time course of what is happening. And you start with there was one sick person, and they're all randomly just kind of banging into one another, and it takes a certain amount of time, but everybody gets it, and presumably everybody recovers. Now, in Titus County, we have a death rate of about 1.7 per 1,000, I believe. We'll look at that number when we get down there further. And it's actually on the lower side, but if you had 200 people and you had 1.7 per 1,000, you'd probably get, a death or two out of there. But you can see how quickly this spreads and how completely it spreads, considering everybody lives in this town and they all kind of associate with one another. The next thing we're going to see is a graph so what they tried in Wuhan province, after they said, man, we got this big breakout coming, they locked the city down and the province down, but they didn't do all the math by locking all those people down. And you'll see what happens. People would still have to come deliver groceries, even though people weren't allowed to travel at all and they were supposed to stay in their homes, things would have to happen. So here's all the healthy people in China, here's the Wuhan province, but they isolated them. But as a few people had to interact with the other people in China, you see what happens with just, one or two people getting out of the quarantine. Within, over time, you infect the entire population of both boxes, and they all get it and they all recover. You can see how this curve was flatter and did not come to such a peak, and you also see how the recovery acted. What this next one shows is social distancing. And so you'll see the change over time of what happens if you just don't get out and fool around with one another, or you wear masks, or both. So you can see that a lot of those dots are standing still, and a lot of the dots, some dots are moving, and they're the ones passing it around. And you can see that you have a curve that's coming up that is definitely flatter. And so you can see that the number of people that are infected with this model, instead of being all 200, is you're getting, more than 3/4 of them get infected, but it happens much more slowly and with just more time to intervene and prevent further spread by having more people socially distanced. Now this is social distancing. This one up here was one out of every, what is it? Yeah, three. I think it was one out of 4 social distance. But now here, one out of every, I think, 75% of the people in this 200 person population social distance. And so you have originally 12 people running around, but you can see how the spread of this virus is much slower, and you can see by the curve it's almost imperceptible. So, 1 of every 8 persons was allowed to move around, and that's what we had hoped would happen initially. And you probably all remember, if you were working here, we all got letters signed by Mr. Scoggin that said, hey, you guys are essential personnel. And so, you have this letter. Well, it never came to that, but if it had, we might have actually been able to eliminate the virus with physical activity. And you can see even the ones who got it, who are moving around, they recover, and then they're no longer infectious. So that really kind of shows when it's a free-for-all on the left, everybody gets it and most people recover, and good luck with that, because we know that a significant number of those people who get it are going to get sick, and a smaller number are going to die, and that's obviously a big deal. At an attempted quarantine, you have the people who are quarantined, they all get it, but you lock them up. But if just a few people get out and everybody else is not social distancing, well, here you go, and then everybody in the population gets it. Moderate distancing, which is 1 in 4 people isolates or at least distances and wears masks, you get this curve flattened, certainly compared with on the left. The third one over shows it significantly flatter. Then with extensive distancing, you really can this is 1 out of 8 people moving about freely. And this doesn't take into account wearing masks, but you can see that it clearly helps with, it prevents the spread of disease. And this is a pestilence like we've never seen, and it's going to spread no matter what you do. So if we look at we'll pull up the next video. Let's look at how an mRNA virus works. And so that will be, and how a virus, oh yeah, this is great. Well, that's a vaccine. Hang on. You don't want that. We don't want that. Nope, that's vaccines. So how coronavirus spreads through a population, and how, so this just, this shows what's kind of cool about this. All right, we're going to go through a bunch of stuff. But what it does is it lets us see how the virus will spread. The R value is kind of how many people the person with the virus gives it to. And as that goes up, you get a population that gets hammered. And so when we get down to the bottom of this, it's kind of cool where you can adjust these things. And you can adjust the fatality rate, the susceptibility rate, and that is really kind of the vaccination rate, and then the isolation rate. And so a row of 2 means that one person gives it to another person, and you can then see how the virus spreads. And this is the percentage of 1,000 people. Let me see because the dots will change if I can get it to work properly. Okay, so we're watching it spread. So with a row of 2, fatality rate of 1% and susceptibility of 80%, that means most people can get it. You see that it spreads in that population. You can see that the blue dots are people who died and the brown dots are people who got the infection. And you can look down in the lower left and you can see that really ramp up, and you can see that there are 800 people in this group, 800 got infected and 8 of them died, okay? And that was with a row of 2. Now, if we take this population and we make kind of what was estimated initially for a row of 10, in that everybody who got the virus was probably going to give it to 10 other people, or say they were just real infectious, and you start that, and with just 3 or 4 iterations, everybody's got it. That didn't take any time at all for that to happen. With a fatality rate the same, you see about the same kind of the same thing happen. If you dial row back to 1 or less than 1, then everybody who gets it doesn't necessarily pass it to anybody else, and you can watch how slow this thing spreads. Chickenpox has got a row of about 15 to 20. So, because it's extremely contagious, and if you set that up that high, hello, 4 shots and everybody's got it. So those exposures are really important. If we go back to a row of 2, and then we put susceptibility, there we have 80%. Let's say that half of the people are vaccinated. Let's do Titus County. So about 40% of people in our little group are vaccinated, and the isolation rate is 0. So we have 40% vaccinated, and you can see with every generation of the illness, if we're not wearing masks and we're not walking around, and only 40% of us have either had COVID or been vaccinated, you can see that 6 people died, and pretty much 600 of the 1,000 that are here got infected. So once we crank this up to, let's say, 70%, we're talking about this herd immunity, and all that means is that everybody in the group, or enough people in the group, have been vaccinated or had the illness so that it no longer spreads. So if you have a row of 2 and 70% vaccination with no isolation of the people who get it, it will still spread, but it will be really slow. If we can get, let's say, 8 out of 10 people to isolate while they have the illness, so an isolation rate of 80%, we're going to watch it spread. And wow, so far we have 7 cases out of 1,000 and 12, and you can see how this is slowly growing. But if we had an isolation rate of 100% and somebody got it, let me get it to start over again. Oh, quit fussing with me. Let me change something again here just to see if it'll restart. Okay, well, that's neat. Well, that decided not to work. Let's look at what the Delta variant could do. And so I clicked on that. We'll start the Delta variant, and that thing spreads. It's got a row of 6, even with some limited social distancing. And you can see that it just ripped through everybody. 7 out of 10 people got sick, and 7 people died if you have a death rate of 1%. So you can see how quickly that went through. If you have no intervention at all, then we'll see, a row at 2.7, 70% susceptible, isolation rate of 0, and then you put in a strong intervention, which is 30% vaccinated and 40% of people isolating. You can still see you get a lot of cases, but they don't spread you it limits the number. Where here a total of 400 out of 1,000 got it, and 2 died. But if we take the susceptibility down to 20%, and even an isolation rate of 40%, and we watch how it spreads, a few people will get it, but it's nowhere near the number that would become ill. And if we could get people to get vaccinated and isolate if they got it, then the rate would be, would be almost zero. We see 4 people out of 1,000 developing the illness. So that's the point of getting vaccinated. And also, as we vaccinate, the mortality rate goes way down. That is, as we get vaccinated, you'll still have a few people who are vaccinated get the illness, but they won't get that sick. Your hospitalization rate drops from, say, 1 in 8 or 9, 10 people or so might need to be hospitalized. That rate drops to about 1 in 100 to a little more than that. So, and remember, immunizations don't prevent you from getting infected with the illness, but they absolutely prevent you from getting very sick from it. So this is just a little thing about infectious disease biology, but I think it goes a long way to actually put in your mind what we're talking about when we look at how the infection spreads, because it doesn't go, just having someone talk about it doesn't really tell you as much as you might wonder. Let me look at, I wanted to find one more thing here. Okay, here's a little video, and this one may be kind of stupid, but let's see. We're going to look at
the coronavirus, which causes COVID-19, originated in the city of Wuhan, China.
We don't care about that. Let me see.
COVID-19 is believed to be transmitted primarily through inhalation. Once infected, most people experience mild symptoms, including sore throat, headache, fever, a dry cough, shortness of breath, and fatigue. However, in a subset of patients, the virus attacks the lungs, causing a much more serious infection. Small air sacs in the lungs add oxygen to your blood cells. This oxygen is then transported to organs and tissues throughout the body. When the coronavirus attaches to a cell, it begins to replicate within the cell. The body's immune system attempts to destroy the virus, which results in an inflammatory response that causes fluid accumulation in the lungs. As the lungs fill with fluid, the body's available oxygen decreases, which can lead to organ injury and death.
I want to bring out one important point, because the thing that we see that really sets people up, it turns us into a fatal disease, is you have widespread inflammation within the lung. And if you think about the anatomy, which is really important here, the way the lungs are put together is you have these, they're called arcades of capillaries that run next to the alveoli, and you have tissue, you have some basement membranes and tissue that go between the capillaries and the alveoli. But as you get more fluid in this separation between the capillaries and the alveoli, the ability of oxygen to diffuse down its gradient, and that's kind of a scientific term. That means you have a lot of it here and very little of it in the bloodstream. So some of it will make it in there, will be taken up by hemoglobin. Because you have that situation and that you now have a much larger diffusion barrier, you can see that not much oxygen is making it through from the alveoli to the bloodstream. And that's one reason that we see people who are just profoundly hypoxic, but they, their blood pH is okay, and that's because they're able to breathe out and blow off all the carbon dioxide, because carbon dioxide can get through that membrane because it gets through water, which is all this stuff is mainly water. There's inflammatory cells and cytokines and all that other stuff that we hear about. But if you took a lung, if you took my lung, one of my lungs out of my chest, it'd probably weigh about 600 grams. So, it's just barely, over a pound, not even a pound, if it was normally perfused. If you take, you give me COVID, and I get COVID in maybe even 70% of my lungs, the weight of my lung is now almost 2 kilograms. So this is heavy, and all that water isn't floating out here in the alveoli like you might see in heart failure. All that fluid is in between the place where the oxygen comes in and the place where it needs to go. And this is how people end up dying, is they just can't get the oxygen to make it through that big barrier to get to the bloodstream where hemoglobin can take it up and hold it captive until it gets to the tissues like your brain and your heart and tissues like that. But so just really understand that it's this transition to the pulmonary phase, which is the life-threatening phase. And not everybody has this phase. In fact, only a minority of patients will go down this track. And, we've talked about how in the what we call the natural course of COVID, people get infected at day 0, at about day 2 to 3. They begin to have symptoms. At day 2, they're infectious but don't really know it. And then by day 5 or 6, a lot of people are feeling better. I've taken care of a lot of people, and then a lot of kind of people in the community, even other doctors. And more than one of those people transitioned to the pulmonary phase. And about day 3, they were kind of panicky because you're like, man, I'm sick and I feel horrible and I don't want to get sicker. Well, you give them medicines and they get better. And most of them completely recover. But 1 or 2 of those people will go on to the pulmonary phase. And so at day 5, they say, hey, I feel great. I want to go back to work. And you say, well, let's wait a couple more days. And so you get to day 7 and 8, and they say, hey, man, I just had a fever. And you call them, and their temperature's 103, and you go, oh, crap, because somehow this virus is set up shop in their lungs, and this is where things get serious. And that's why and this is where the monoclonal antibodies don't do any good, because once it's set up in your lungs, it looks like the Regeneron, which is the monoclonal antibody that we've given 1,000 doses of, doesn't help. If you give Regeneron prior to even sometimes it's 7 to 10 days, and even as long as 2 weeks, but if you can give it within the first 5 days of somebody being diagnosed with COVID, they will and I would say never progress to the pulmonary syndrome. It's because you're just taking so much virus out of the bloodstream that the Regeneron literally helps you recover from this quickly. And the monoclonal antibodies do what your body will do the next time you get infected with COVID, which is make a ton of antibodies and take that biggest percentage of virus and just dispose of it. And so this is why this whole fluid thing is a huge issue, and why the pulmonary part of the disease is, just a really unfortunate, event. And we've had people even in their 20s die from this, and we don't know why they were susceptible. We don't know why, this would happen the way it does. So let's look. Oh, we did that already. So this is a really piddly video about how coronavirus vaccines work. And this is really important because it's gonna give you kind of an idea of how the vaccine gets in your bloodstream and how you make antibodies and how it protects you. So let's watch this real quick. I think this one
so far, about 100 million people have been infected by COVID-19 worldwide, and the disease has claimed the lives of more than 2 million people. Today, a variety of vaccines have become available to effectively control the pandemic. The The main difference between modern and traditional COVID-19 vaccines is that the modern mRNA vaccines do not contain the whole virus, but only the blueprint of an important component of it, called the spike protein. With the vaccine, only this blueprint, a short piece of RNA, enters our body without altering our genetic code. This small RNA sequence, when injected into the muscle, initiates the production of spike proteins, and then it degrades.
So I just want to point out, this is what we kind of haven't been told, at least in a greater sense of how the virus works. It has to do with the spike protein, and that's that thing that sticks out on the surface of the coronavirus that the monoclonals generated, the Regeneron agent binds to these, and most of the antibodies that your body will make if you get COVID binds to these. So what this does is it just gets into some muscle cells and they make a ton of spike protein, and then you'll see what happens to the spike protein.
With traditional vaccines, the viral proteins, including the key spike protein, are injected into the muscle, usually in the form of inactivated viruses. The subsequent process is similar for all vaccine types. Immune cells patrolling the body present the spike protein as a foreign material to the helper T cells, the conductors of the immune system.
And you might remember some of this from nursing school. I remember a little bit of it from medical school 30 years ago, but it's good to know this mechanism because it'll let you be able to tell people kind of what's going to happen, and that it's not some magical process and their DNA is getting rewritten and rearranged.
These T cells alert the executors of the immune reaction, the killer cells, and the antibody-producing cells. These cells are capable of protecting our bodies from the attack of the virus, while also creating memory cells that remember the spike proteins of the coronavirus, which are prepared for a later virus attack. The most important outcome of vaccination is the development of immune memory. If the coronavirus attacks after this, it has little chance of success. Antibodies cover the virus and thus prevent it from binding to our cells to cause infection. Cells that have already been infected are ruthlessly destroyed by killer cells, along with the viruses inside. With vaccination, 90% of the infections do not develop into a disease, and if they do, the course of the disease is much milder than without vaccination. These coronavirus vaccines have been given to several million people worldwide who have become protected against the development of the disease.
Okay, so this brings up some important points, but I hope that it helped at least put it in a cartoon, in a cartoon manner, how vaccinations work, and what they were showing in the second one, where this is how
usually in the form of inactivated.
This is how the flu vaccine works. Is just what they're showing in the second one.
Into the muscle.
And this is showing a coronavirus particle that's inactivated. And this is how the Novavax vaccine works, which is about to come out probably in the next few months. And this is what a lot of the anti-vaxxers say, that, well, I'll take that vaccine because it's like the other vaccines. But all that happens in this is really the same thing, that the vaccine gets into the muscle takes the whatever genetic material is in the virus and transcribes it without the virus being able to reproduce, and then your body makes antibodies to that. And this is what they're doing by using an mRNA virus, or an mRNA particle, is those get into the muscle and it makes just millions and billions of the spike protein, and then your body just has that one antigen to process and get a whole bunch of antibodies that will eliminate it. But what it comes down to,
usually in the form of inactivated viruses,
is the natural killer cells and the memory B cells. What happens in the body is truly amazing, and if you if you looked on the internet to see kind of how this all happens. These helper T cells, they go to the spleen and liver mainly and say, man, there's some stuff going on out there and we need to take care of it. And what happens is these helper cells are able to stimulate just very specific single, or just there's a few copies in our spleen and in our liver of cells that don't even know what they're immune to. They just have these antibodies sticking out on their surface, and they're kind of like, hey, we're not doing anything. But all of these cells are made before we are even born, and they go dormant and they sit in your spleen. But when this helper T cell cruises by, it's showing this antigen antibody complex on the surface, and when it runs into one of the lymphocytes or the killer T cells, it activates it, and you have such an explosion of copies of the helper T cell, or the lymphocytes and the killer cells, that it's what's called clonal expansion, but you get this massive growth of immune cells that is now, it only has one job, and these cells don't have brains. All they know is we make antibodies, and the killer cells, like, we go and we kill everything that has this spike protein on its surface. And so when a cell in the lungs gets infected with the coronavirus, the coronavirus gets into the lung cell and makes more protein. Some of that sits on the surface of the lung cell, and then the killer cell cruises by, notices that antigen, and just explodes. It kills itself, but it also kills the cell that was infected, and that's how our bodies deal with viruses. We kill our infected cells by literally an explosion that destroys the membrane and the cell dies, but in most cases, a new cell will grow up in its place. But it's this clonal expansion of these B cells. What they're doing is they are cranking out antibody, and so what happens is those antibodies get produced, and they go to fight the initial infection. But then these B cells circulate all throughout the body, and they take up residence in almost every tissue of our body, so that if that antigen ever gets in again, they undergo that whole clonal expansion immediately and start pumping out massive amounts of antibodies. And for the initial infection, we had probably no antibody to COVID in our bloodstream, but after this clonal expansion for the first infection, we may have, say, a million, let's just say we had 1 million antibodies produced that could go and take out COVID. When you've been vaccinated, and now this one cell is now 1 million cells, and each one of those million cells can become activated and make 1 million antibodies, you now have trillions of antibodies in your bloodstream. And that is enough to take out COVID. And this activation happens kind of slowly the first time. It takes 2 or 3 days. But now there are the helper T cells that recognize it. Other cells in the body, when the infection gets in, these B cells get activated so quickly that they go through and they just slaughter COVID. And that's why people who are infected after they have been immunized just don't get that sick, because all this memory is stored in your body. Now, this brings us to kind of the need for booster vaccinations. And I want to try and explain. Here, I'll move this over here because it's cute.
If the coronavirus attacks after this, it has.
So you can see these antibodies made from this B cell. What they've done is they can measure antibody levels in your bloodstream. As you've been vaccinated, the antibody levels come up, and then they start to decrease. Okay, so they're decreasing. So what does that mean in terms of the body's ability to respond to the infection and prevent the infection from making somebody sick? And we don't know the answer to that. That's because this is really one of the first times that we have the technology to measure antibodies in the bloodstream when we've had a pandemic. And so The decision to give people booster shots really came from a large study done in multiple medical centers of medical providers, or just health providers like nurses and staff and doctors who'd been vaccinated, to see how long it was before that infection rate with COVID became significant. And it turned out that it was about 8 months, where there seemed to be a little rise in the number of people who were getting sick after being exposed after 8 months of being fully vaccinated. Now, of those people, really, I think maybe one person died of thousands, and it had something to do with a disease, the pre-existing condition. And we know that people who are immunosuppressed don't have as strong a response to the vaccine, to the spike protein that's eventually pumped out into the bloodstream and recognized. They don't have the ability to expand those clones of the T cells and the B cells that will lead to good immune memory. But we know that a third injection, which we're calling just the additional dose, will help expand that even more. I think we're probably overreacting, and the big committee on do we give boosters or not said, no, we don't really need to. But then the CDC, smaller committee, and the people in charge said, yeah, we're going to do it. And I think that's because we just don't know whether the amount of antibody in your bloodstream correlates with how sick you're going to get. We don't know any of this, and so we're going to learn a lot from COVID. But the prevailing thought is, if you're kind of normal like me, and your immune system kind of works like mine probably does, then you are probably still well protected. And we don't know if this protection is going to be lifelong. We get a tetanus shot every 10 years, and that's to protect against a bacteria called Clostridium tetani, which can make you, which can kill you. But we know that it lasts for 10 years and probably longer, but we give boosters every 10 years because I guess the vaccine producer would go out of business if we didn't do that. But we don't know, because we just, there's tetanus everywhere, but we all have pretty much been vaccinated. And, I can say that I have not cared for anybody with tetanus in my lifetime. I was going to say that other than HIV, until 2 years ago, I could say I've never had to take care of anybody that had, a pandemic illness. But, this has been just such a re-education based upon, this horrible pandemic we're going through. But, we learn how to fight it better, and, how to kind of recover from it. That's really the point of the vaccination. It's naked RNA, which is fairly quickly broken down in the bloodstream, but the RNA gets into the muscle cells and makes a ton of spike protein, which by itself is harmless. But the spike protein gets recognized as foreign, and your body just comes unglued at making antibodies to it. And so with 2 doses and now 3, you have a really, major degree of protection. So let's talk about what makes people really sick. It's called cytokine storm. And, this is where the bacteria gets into the blood, or the virus is in the bloodstream and goes to the lungs, and then cuts loose with this inflammation. And this is a 5-minute video that kind of shows what happens. So we'll run this really quick. So that's a bunch of people with COVID, and then a bunch of astronauts in there with them, dressed up in all the gear. There may be a voice with this, but I'll try and shut up if there is. we treat with massive amounts of steroids and also anti-cytokine antagonist, which one is Actemra and the other is baricitinib.
When the antibodies are sufficient in number, the viruses are in large number, and there's a fight between the two. And in this fight, there are what are known as chemicals released into the bloodstream. These are known as cytokines. And these chemicals cause the body to have a higher temperature. They have fever, body to have myalgia, body aches. If it is a throat infection, they have sore throat because the cells there in the throat have the maximum number of viruses. It causes a little cough from that irritation there. So these are consequences of the virus being there in the body in large numbers and the fight going on.
I didn't know Gandhi was a doctor. I'm sorry, that was horrible. He looks like Gandhi. So these cytokines help us to fight infection. In fact, they're a big part of what happens during vaccination. Like it says, if you get too much cytokine, like an explosion, you can die. And this is what kills people. It's not the virus itself, it's the storm that you have that eventually gets into the lungs and causes all those membranes to get really thick between the blood and the oxygen, and no oxygen equals no life as we know it. So that's what happens, and he'll explain. And so what happens when you have this massive cytokine storm, you have a lot of proteins get broken down and structure gets broken down, and the lung tissue starts to look a little bit more like a baseball glove than it does lung tissue, which is really baseball gloves made of leather. And so it's a lot of connective tissue and a lot of swelling. So, and this was made obviously by a company that makes a cytokine storm inhibitor. So it's a little bit biased. But they are making progress. You can see this is a way of predicting this. And you know, we look at the inflammatory markers, especially C-reactive protein, is when there are a lot of cytokines in the bloodstream, you have a lot of C-reactive protein produced, and we can measure that. We can measure cytokines, but they're at such a small amount that it takes something called high-performance liquid chromatography or gas chromatography to measure these, and it takes a week to purify and figure out how much these are, how present they are. And now we do have baricitinib, and there's Actemra, tocilizumab, and it really seems to fight against this storm, and really that's all we have is anti-inflammatories, and by suppressing these strongly enough, it really looks like we are able to decrease the amount of inflammation within the cells and save people's lives. So we have 10 minutes left. I know that we have at least one question, if you want to turn the camera on. So this comes from the always sassy Nikki McGee. It says, what is causing the pneumothorax and pneumomediastinum the ventilated COVID patients are seeing? And so a very good question. And, you know, we have seen pneumothorax and pneumomediastinum in more patients than we've ever seen before. Pneumomediastinum means, you know, the mediastinum contains the trachea, the superior and inferior vena cava, the esophagus, a whole bunch of structures, a lot of the phrenic nerve, the aorta. So, we know air being in there is a big deal. Now, before COVID, if you ever had a patient with a pneumomediastinum, it meant almost 100% of the time they had a ruptured esophagus. And because there's a lot of bacteria in the esophagus, it'll get into the mediastinum where all the important organs go, and you'll die. And so the immediate treatment was surgical exploration. But we've had a number of pneumomediastinum and episodes, and in most cases, they actually just kind of get better on their own. The first few patients that had pneumomediastinum, we shipped to Tyler, and we eventually got these people back. So a couple of them came to rehab, and we thought, oh my gosh, they cut their chest open, what'd they do? And they're like, nothing. They just got better. And so it's amazing how this happens. And we've seen, it's a different type of pneumomediastinum and pneumothorax than you get from another event, but it's a whole new type. And it seems to occur most often in people who are getting BiPAP or are being mechanically ventilated. This is obviously because there is so much water in the lungs. If you've taken care of COVID positive patients or hospitalized patients, these people are working to breathe, and it's because there's so much water in the lungs that they can't inhale forcefully enough to get the air in and even get the CO2 out. They do easier with the CO2 because it's so much more diffusible. But so these people are working hard, and so when they're on mechanical ventilation, you have to use an external pressure, and those pressures have to be higher than we typically see, both in CPAP and in mechanical ventilation. And we think that, if you look at anything like a board or an airplane fuselage, the place that breaks is always where you have stress concentrations. That is where all the pressure gathers up in one spot to break whatever it is that you're talking about. And in the lungs, it happens to be the alveoli. And we don't know if it has to do with coughing, what it actually has to do with. Some people have noticed that it seems to be when you're moving a patient around, say to provide personal care or do a procedure, that many of these pneumomediastinums and pneumothoraces occur. There has been a small bunch of anecdotal data published by numerous centers where they paralyze people for the entirety of their stay on the ventilator, and pneumothoraces and pneumomediastinum still occurred. So to answer the question, Nikki, I don't know. I think, as a critical care nurse and supervisor, you know that the lower pressures that are required to provide adequate oxygenation and ventilation are desired. But in this disease, because the weight of the lungs is increased between 2 and 3-fold, that's 2 and 3 times, and it's all water, that now the distensibility of the lung becomes much lower, and so much higher pressures have to be used. So I hope that was useful. So Grandpa's going to see if they can read this. There's Nikki's question. Which one am I looking at now?
Look at the one from Tim Hefford next.
Okay. Oh, there it is. We know vaccinated hosts have a clinically significant decrease in progression to illness. True, but it can and has been, documented, as well as a very small number of deaths from people fully vaccinated. I understand. I said no deaths post and timely monoclonal antibody therapy. So when I was talking about no deaths, that's been in our facility. There's an old, monoclonal antibodies don't prevent death, but they absolutely do change the course of the illness. I hope this is answering your question, Tim. Well, what we see is if you think about, so there's this old doctor saying that if you're a surgeon and you take out appendices from people with appendicitis, if you don't take out any normal appendices, like you don't take out a normal appendix every once in a while, you're missing some that you should be taking out. And so this, this is understandable. So the idea that there are criteria that are fairly strict, and the main one is no significant hypoxemia in people who receive the monoclonal antibodies. Well, we're trying to give it a little more liberally than, we don't want to exclude people unless we really have to. And I think, at many centers, maybe once in a while here, we might give monoclonal antibodies to somebody who really didn't qualify, and they still may get sick. And that just means they really didn't have their effect. And so the antibodies, are not 100% effective, but they are amazingly effective because we have given so many doses of it, and to so many people with so many comorbidities. There was one of the local doctors referred somebody who had lupus and was on significant immunosuppression and weighed 450 pounds and wasn't 9 feet tall. So they had and was diabetic. And so they had the big risk factors. We got him in, gave him Regeneron, and we never heard from him again, and he didn't die. He came back to see his doctor, and he was fine. And I mean, this is a major big deal because just people who are heavier, like I don't want to get COVID because I'm a big dude and I'm kind of fat, and people that are kind of fat like me don't do really well, and it gets kind of proportionately worse as you get heavier, and so it's a real tough thing. Tim, Laney brings up a good in case management brings up the question, could monoclonal antibodies be used as prophylactic treatment? And yes, they are actually approved for that. And about 8 weeks ago, the FDA approved for, in June, they relaxed the criteria for who qualified. And then again in August, they approved it to be used for prophylaxis. And that is if somebody who is susceptible to severe disease is exposed, even if they're not COVID positive, they are allowed to receive the monoclonal antibodies because it has been shown very strongly to prevent people from seroconverting. That is, people who were exposed to COVID don't get COVID. Now, there are some that did seroconvert and eventually swabbed positive, but they were almost unaware of their illness and and they didn't get severely sick. In fact, only of the total number that were assessed, which was over 1,000, only like 2 people even knew that they had COVID, and the rest of them did very well. So. We're getting toward the end, 1 minute and 48 seconds approximately. I hope this has been helpful. And, if you can tell people, if you're able to get the point across about the vaccines, there is a theoretical possibility that this RNA could be spliced into our DNA. It actually kind of wouldn't work because it'd have to be RNA turned into DNA, and then you'd have to gather up a bunch of things called CRISPRs, which are these little devices that can be used to edit somebody's DNA. They don't, and to cause cancer, you have to have activation of something called an oncogene, which is something that causes rapid transcription of certain genetic elements. You would have to have so many things happen, which have just never happened. And they are inherently safe because of the RNA nature of it, and they just make spike protein, which is just a protein. So I hope some of this was useful. I'm sure the links will be available. There are a lot of good cartoons out there, and I'm more of a baseball coach, and we just tend to go hide out in our campers and drink beer like my high school baseball coach did. I don't do that. But these cartoons and these videos can be really helpful, and they can maybe explain it to some of the people you know. So get everybody that you know and love vaccinated if you can. You're going to save some lives. So I appreciate everybody being here. If you're not going to get vaccinated, then you need to breathe really shallow, keep your eyes and your mouth closed, and not get near anyone with COVID. Everybody have a good Wednesday, and thanks.